Welcome to Team Phenomenal Hope's third annual town hall. Today, our 2021 winner of our research award, Dr. Nicole Ruopp of Tufts Medical Center, will present her findings from the past year. So we started our research award program, the Phenomenal Impact Fund for Global pH Research, in 2019, and every year since, we have presented a $50,000 research award to an investigator in the field of pH. So we're just so pleased to be contributing to the advancement of research and treatment. Before we get started, I'll hand things off to Team Phenomenal Hope's board chair, Dr. Hap Farber, just to share a few things and introduce our presenter.
Okay. Can you guys hear me?
Yep, we can hear you.
Okay, so I'm Hap Farber, for those of you who don't know, and it's really my pleasure to introduce Nikki Ruopp, who's going to talk to us today. I've known Nikki ever since she was a fellow at BU, and she, from the beginning, showed a tremendous knack for pulmonary hypertension, and it was granted our pleasure to award her the research award, as Katie mentioned. And so Nikki actually is very interested in right heart failure in PAH or PH. So Nikki's going to actually talk to us about multiple aspects of PH today, of which she's immersed herself pretty much now for the rest of her career. And hopefully this will be as educational as I've found the talk. And with that, I got nothing else to add. Nikki, take it away.
Thanks, Hap. So thank you all so much for having me. So our research focuses on right ventricular failure and mechanical support, developing mechanical support devices for the right ventricle in pulmonary hypertension. And so we're going to kind of talk a bit about that today before we go into the project. So to start, I don't have any disclosures. So just going through an agenda for today. First, we're going to divide the talk up into about 3 parts. We're going to talk a little bit about pH and how it progresses and how that affects the right ventricle. We're then going to talk about when the right ventricle is failing, how we manage that, particularly how we manage that in the ICU. And that's where the mechanical support devices will also come in, and we'll talk a bit about the project that we've been working on. And then I'll finish with a case that I think highlights really nicely the importance of the work that we're doing and that Team Phenomenal Hope has helped to sponsor, and how that can be used to help patients going forward. So let's get started. So many of you probably know this. Pulmonary hypertension is divided into 5 groups based on similar underlying causes and similar disease types. The one that you may know more than others is pulmonary arterial hypertension, which is group 1. That's actually one of the rarest forms of it, and is one that we do treat. The more common ones that you may or may not know are group 2 and group 3, pulmonary hypertension from left heart disease, and then also from lung disease. Those are much more common and probably the most frequent types that we see. And then we have group 4 and group 5, which are pulmonary hypertension associated with blood clots in your lungs, or CTEPH. And then group 5 is kind of a mixed bag of a lot of hodgepodgey types of pulmonary hypertension. The reason I highlight this is because predominantly we focus on pulmonary arterial hypertension, but all of these forms ultimately can progress and involve, right ventricular failure, and therefore all can, on some level, be the target of what we're talking about today as well. And so I wanted to highlight that. This is kind of a more definitive breakdown of the different types of diseases that are associated with each group of pulmonary hypertension. And so, not to belabor them because many of you know this, and we did kind of talk about some of it, but certainly for group 1, we have connective tissue disease, HIV-associated pulmonary hypertension, and then idiopathic and heritable. And then you can see examples of heart disease that can cause group 2, lung disease that can cause group 3, and then again, group 4 and group 5. So keeping in mind, as I said, that, all pulmonary hypertension can progress to involve the right ventricle, especially pulmonary arterial hypertension, I wanted to kind of go through how that works. And so in pulmonary hypertension, one of the key problems that we see is that the pulmonary vasculature is narrowed, and that causes an increased resistance. The right heart pumps blood into the lungs, so into that pulmonary vasculature. And as the vasculature narrows and gets this increased resistance, it increasingly strains the right side of the heart, which just is really not the most robust muscular side of the heart. And in response to that, the RV can work a little harder and it can keep up for a period of time, but eventually it will kind of start to tucker out if something is not otherwise acting on the pulmonary vasculature to kind of decrease the resistance. And what we see when the right heart starts to kind of tucker out is we see that the right ventricle gets bigger, it gets more dilated. And at times it starts to bow into the left side of the heart. When that begins to happen, the RV really starts to not be able to keep up well at all. These adaptive changes that it's made, this getting bigger, this bowing into the left side of the heart, really don't allow it to contract well. And so it kind of becomes this feedback cycle of, the more resistance there is, the more the right heart dilates, and the more the right heart dilates, the less well it pumps. And we kind of get into a feedback cycle. You can kind of see that, or hopefully you can see that on this example that I'm going to show you. So in a normal heart, the left heart is the much more robust side of the heart, and the RV is kind of thin and really not so impressive and really on the smaller side, both when the heart is completely filled with blood and also when it's contracting and emptying. In a pulmonary hypertension heart, though, especially one where the pressures are elevated and the right heart's really not responding so well to those pressures, you begin to see that the right heart gets more dilated. And as it gets dilated, it begins to push on this left side. And you can see that the left side then becomes smaller. And this is an example of that on an echocardiogram. So all those echoes that we have you do, this is one of the reasons why it allows us to monitor what's happening with the right side of the heart. I think this kind of shows it even better, and that's why I really like this slide. So this is kind of the heart in cross section. So this is the right atrium where the blood flows into. This is the right ventricle. It goes out to the lungs. Oh, sorry, my slides took off on me. Goes out to the lungs, and then this is actually the left ventricle of the heart, so the left side of the heart. And you can see exactly what we were saying, that the blood has the right heart has responded to that increase in pressure by getting much bigger than the left side of the heart, and it has bowed into the left side of the heart. So it's really bigger. It can't contract well in that setting, and it can't deliver blood to the left side of the heart very well because it can't contract well. And even if it could, the left side also is limited in its ability to receive blood because the right heart is so big. And so really this heart's not doing well, and it's for multiple reasons, but it really all stems back from the right ventricle and the load that the right ventricle is carrying. And that can be pretty typical of what we see in more advanced or decompensated pulmonary hypertension. And this is just another example of that. So you can see this dotted line is the resistance in the lungs. So as the resistance goes up, the pressures in the pulmonary vasculature go up. And as that happens, this is how well the heart's functioning. The heart function starts to go down. And we know that that's not good. We know that when the right heart begins to dilate and not work as well, that's when we find that patients end up getting admitted to the hospital. They come in with volume overload. They come in with worsened symptoms. And we know that both that clinical worsening and the hospitalization are associated with doing less well. When those things are happening, patients are at risk of decreased survival. And so it really is a problem that we are, actively working to try to understand how to better manage. And as I said, so we know that being hospitalized for pulmonary hypertension puts you at an increased risk. And we know that clinical worsening puts you at an increased risk. And we know that when the RV fails, you again are at an increased risk. So we have to begin to better understand how to predict and how to support RV failure in these settings so that we can help, patients, you all get better. So to kind of better understand some of the factors that we think about and how we manage these patients and this right ventricle when patients come into the ICU, we're going to go through a really quick, hopefully helpful model of how the right ventricle works. And so I'm gonna take you through my handy dandy design here. And I'm not an artist, so apologies if this is pretty simplified, but taking you through. So blood, this systemic circulation is blood coming back from your body to the right side of your heart. It goes from your right atrium to your right ventricle, out to your pulmonary circulation. So your pulmonary vasculature, where the pulmonary hypertension is, gets oxygenated, comes back to the left side of your heart, the left atrium, the left ventricle, and then goes out to your body, and round we go. Okay. So let's talk about some of the key things that we think about that the right ventricle needs in order to function. Because when patients are decompensated, end up trying to act on or modulate many of these things in order to better support the right ventricle. So the right ventricle, and this may seem very silly, but the right ventricle depends on something called systemic venous return, or the blood return to the heart, or preload. And intuitively, if you think about it, that makes sense. In order for the right ventricle to be effective at pumping out blood, it has to get blood into it, and it has to get enough blood into it that it can squeeze out the amount that it needs and send it on to the lungs and to the left side of the heart. So that's one thing that impacts how well the right heart functions. The second thing that impacts how well it functions is something called the RV afterload. And this is particularly meaningful in pulmonary hypertension. The afterload is essentially what kind of force the right ventricle is pumping against. And in pulmonary hypertension, that is increased resistance in the pulmonary vasculature and subsequently increased pressure in that vasculature as well. And so you see here, when you have something that ends up putting a blocker to the outflow of the right side of the heart can struggle with that. Pericardial compliance is simply that the right heart sits within a sac that's called your pericardium, and it can only get as big as it can get within the confines of that pericardial sac, and that actually can act as a limitation, but we won't talk about that as much. And then probably also intuitively compared to the preload, the right ventricle, of course, depends on being able to contract. And so it needs to have its native contraction to be able to not only fill, but to empty back out again. And anything that limits that contractility can cause worsening failure as well. So with all of that in mind, now we're going to talk about how we manage a failing right heart in the ICU. And hopefully it is helpful for you. So as we've said, the failing right heart, therefore, has a list of special weaknesses, things that really do make it even more prone to failure if they're not managed right. And in the context of pulmonary hypertension, I want to highlight these again. So you can see that this is the right side of the heart. This is that same picture that I was showing you earlier. And you can see how big and dilated this right side of the heart is. And so it definitely does need a certain amount of blood return so that it isn't empty. Too little blood return, and it's not going to be full enough to actually really get anything meaningful out. But if you have too much blood return, if you have too much volume, say if a patient is volume overloaded, then you can dilate these chambers even more. And that feeds further into the problem of making the right side of the heart, the function go down even more. And so, you're really kind of walking a tightrope in terms of getting enough blood back to the right side of the heart that you have an adequate output, and not so much so that you're making the whole problem worse. The right ventricle and pulmonary hypertension is especially afterload sensitive, as we talked about, because it's already failing, or can be already failing from the load that it's carrying from the pulmonary vasculature. And then because it's already kind of, say this particular right ventricle, for example, is really on the struggle bus. Anything else that impacts its function, anything else that causes it to take even a minor hit, really does result in even more decompensation, because it's really trying to use every last ounce of energy that it has to do what it needs to do, and it needs all of those ounces to get out the work that it is doing. So anything that impacts that can cause further decreases in function, and this we just talked about as well. One more thing that we also think about in the ICU, and then we'll get out of the weeds and into the more interesting things, is that the right heart actually, when the pressures that it is facing get really high, it doesn't get as much oxygenated blood from the coronary blood vessels either. And so it starts to get what we call ischemic. So it even though, the heart is sending out oxygenated blood to the rest of the body, it also relies on oxygen itself that it gets from the coronary arteries. And when the right heart is facing a really high load, the oxygen from the coronary vessels doesn't really get to the right side of the heart very well. And so that also can impact function. And it's another reason why we need to work to keep the afterload down on the right side of the heart. We need to get the pressure down that the right heart is having to pump against. So what can we do when a pulmonary hypertension patient comes in and has this acute right heart failure? How can we help them? Keeping in mind all of those things. And really the answer is we do try and target all of those areas that I told you the right heart kind of depended on to function. So we try to, baby the right heart in all of those areas and see how we can help it. And so we use things like diuresis. So we give Lasix, we give torsemide, we give Bumex. Sometimes we need to do dialysis actually to get fluid off fast enough. But we try to get fluid off so that the right side of the heart kind of de-stretches and gets into a more or a less dilated state that is able to function better. And so we work to get that preload down, if you remember that term. We also try to use pulmonary vasodilators in those patients that we can use pulmonary vasodilators in. So patients who have, pulmonary arterial hypertension especially, we try and use pulmonary vasodilators to reduce the work that the RV is having to do against the pulmonary vasculature. We use medications that are broadly labeled inotropes and pressors. But essentially, they are IV medications that we use to help support the blood pressure and to try to help the heart pump better. So essentially kind of rocket fuel for the heart. So the heart's, really not doing so well, and we give medications that try and help rocket fuel it even though it's not doing well, into a better functioning state. And then ultimately, mechanical circulatory support, which is something we'll talk more about. The reality is we do all of these things, and we do them all at once to some degree, but there's a priority there. So when you come in with right ventricular failure, we start, doing many of these things, but we do the first three before we consider mechanical circulatory support usually. So we'll start with diuresis. If we can use pulmonary vasodilators, or up titrate them, say you're already on them, and we just need to kind of adjust the dose to try to get a better handle on the situation that we're faced with, then we'll do that if we can. And then again, the rocket fuel and blood pressure support while we're doing all of those things. If that doesn't work, and in some cases, we'll consider this using something that we'll talk about in a second called mechanical circulatory support. And basically those are just these really cool pumps that we use to help the heart pump better for itself. We'll go more into that. In terms of treatment, there's a reason that I'm going to go through this. For those patients that we can treat, we have, many different medicines that we use to treat pulmonary hypertension. Over the last 20 years, we've kind of had an explosion of available therapies, which is amazing and wonderful. And it's really made a real difference in the lives of our patients. But all of those medicines really target three basic pathways. The endothelin pathway, the nitric oxide cyclic GMP pathway, and then the prostacyclin pathway. And really all of these drugs either work by blocking vasoconstriction or by promoting vasodilatation. So we're trying to either make the blood vessels in the pulmonary vasculature bigger, so that resistance and that increased pressure goes down, and the strain on the right side of the heart goes down, or we're trying to block them from constricting themselves, so that they at least aren't getting smaller. And this is kind of a model of that. So the drugs act on so this is the right ventricle, this is the pulmonary artery, lungs, pulmonary veins, and then the left side of the heart. So the drugs act on the pulmonary arteries by dilating them. That eases the burden on the right side of the heart, so that the right side of the heart can then send blood on through to the left side of the heart easier and better. And then the left side of the heart is also ideally in a better position to receive that, because it's not being impinged by a really enlarged right side, if that makes sense. So who all do we get to treat when these patients come in? And the reality is most group 1s we will treat. We do treat some group 4s. A lot of group 4s can get treated, but unfortunately, we aren't able to treat many of group 2 patients, many patients who have heart disease related pulmonary hypertension, or lung disease associated pulmonary hypertension as well. So, these medicines can be extraordinarily helpful for patients who have progressive pulmonary hypertension. But when you present to the ICU and you have pulmonary hypertension, I can only really use pulmonary vasodilators to help in some patients, not in all. But if you have group 1, I definitely can. The reason that this slide is up is only to highlight one point. So you'll see the blue looks across the blue row across the top highlights all the drugs that we have that we can treat pulmonary hypertension with, all of our pulmonary vasodilators. And there's a lot of them. We have a lot of medications that we can now treat. Unfortunately, fortunately for our outpatients, many of them are oral, but they take several weeks to work fully and to really get a good effect. And so when you present to the ICU with pulmonary hypertension, I really only have a couple of options that I can rapidly titrate, and really only the prostacyclins that I can rapidly work to increase to kind of help get the right side of the heart in a better spot. So for all of these medicines, as wonderful as they are, in certain situations, they're less helpful to us because they just don't give us the ability to be nimble with them and to adjust their dose to see a rapid change in what we're seeing in the patient in front of us. So that's actually where we will start to talk about the fourth option to help treat these patients in the ICU, which is mechanical circulatory support. So as we've kind of already alluded to, trying to get extra fluid off and decrease the pressures that the right side of the heart is seeing through pulmonary vasodilators, that takes time to work. I can't immediately make someone better just by starting those. And sometimes even with the extra support of the rocket fuel and the blood pressure support, I still have a patient whose right heart is really continuing to fail in front of me. So we're working to, kind of make everything better that we can control to help support that right heart as much as we possibly can. But it still at times in certain patients is not enough. And it's become, very clear over time that we need something more in some patients to help us support them until we can make them better. And that's where something called mechanical circulatory support comes in. So mechanical circulatory support is essentially, as I alluded to earlier, simply sucking blood from one part of the body, sending it through a motor or a pump that kind of acts as an outside of the body heart, and plugging it back in oxygenated or not oxygenated to a different part of the body. So you basically reroute it and act as a heart and route it back in, if that makes sense. And in doing so, you take the work off of the right side of the heart. We have several different types of mechanical circulatory support that we use in patients with heart failure. I'm a pulmonary hypertension doctor, but I also work in cardiac ICUs. And so we use this mechanical circulatory support devices in patients with both heart failure from the left side of their heart and the right side of their heart. But we more predominantly use it in patients who have left-sided heart failure. We're really only starting to understand how it can be used in patients with pulmonary hypertension and right heart failure from pulmonary hypertension. But you can see here, and we'll go more into these, that we have several options for these mechanical circulatory support devices. And they basically all route into different ways in the heart. So you can see here one called the Impella RP actually comes from below, and it sucks blood before it goes into the RA. Feeds it through a pump and then exits it in the pulmonary artery itself. So it basically bypasses the right ventricle and decreases the work that the right ventricle has in that setting. Another one that we'll talk about is what's called a tandem RVAD, and that is where, sorry, my pointer has gone away. There we go. That is where there's a surgically placed cannula that sucks blood from the right atrium, takes it out to a pump. The pump does the work of the heart, and then it feeds back into the pulmonary artery. So it's basically like an externalized heart as well. And then there are other options, the Protect Duo and VA ECMO. And we'll talk more about these. The gist of all of these, and don't get in the weeds of them. It's more to understand the basic concept. But the gist of them is that we use these devices and the tubes that connect them to you or to the patient to plumb around the failing right ventricle until we can make it better enough that it can handle not being plumbed around, or in some cases until we can get a patient transplanted. And going back to our previous model, there are multiple ways we can do that. So we can do that by intervening from the right atrium, sending it through the pump and sending it into the pulmonary circulation, like you saw in some of those devices. Or like in ECMO, we can take the blood from the venous side of the body. So from, say, like a big leg vein, send it through a pump and an oxygenator, and then put it back into an artery, also say in the leg, that then sends most of the blood around the heart. So there are a couple of different ways that we can do this that we tend to utilize to try to support these patients. It's really cool stuff. Hopefully, as we're talking about it, you'll see how cool it is as well. Additionally, my grandfather was a plumber, and my dad fixed cars for a living. So this is all kind of in the family wheelhouse as well. And maybe that's why I'm excited about it. So while a device-based approach can help us support these patients, unfortunately, as I alluded to, most of these devices have predominantly been studied in heart failure from left heart disease, and none of them have been well studied in pulmonary hypertension. And none of them are FDA approved in patients with pulmonary hypertension. And that's kind of where our study will come in. Looking more at some of these devices, some of these devices have been looked at. So the Impella RP, the Tandem, and the ProTech are more of external heart pumps that pump basically just around the right side of the heart. We've seen those and we've utilized those in patients who have blood clots that cause acute onset pulmonary hypertension, and also in patients who have pulmonary hypertension that is progressing and we're trying to get to lung transplant. But there have been no formal studies with any of these devices in patients exclusively with pulmonary hypertension. One of the other limitations that we face in some of these patients and using these devices in pulmonary hypertension is that these are motorized pumps. And these motorized pumps really do at times struggle working against the high pressure in the pulmonary vasculature. And so while we have all of these wonderful devices that we can use to help some patients, and we have used some to help pulmonary hypertension patients, we don't, the devices aren't perfect for pulmonary hypertension patients, and they can struggle, some of them, with the increased pulmonary vascular resistance that we see in pulmonary hypertension patients. Probably the one that we use the most frequently, the device that we use the most frequently in patients with pulmonary hypertension who have decompensated right-sided heart failure that's not responding to our drugs and medications, is a device called VA ECMO. And so what VA ECMO is, and I kind of highlighted this for you as in one of the earlier pictures, but you'll see that we take a cannula and we send it up sometimes the leg veins, basically into and around the right side of the heart, where it is designed to suck a large amount of blood from. So most of the blood that the heart sees gets sucked into this cannula. It comes out of the body, goes around through this pump that gives it speed and basically acts as the external heart. It gets oxygenated like it's going through the lungs, even though it's not. And then it routes back around, oxygenated, into a cannula that feeds into one of the main arteries. So there is still blood that goes through the heart like normal, We can't stop all blood from going through the heart, but by taking the vast majority of the blood off of the heart and sending it through this external pathway, we significantly reduce the work that the right heart is forced to do. And that allows us to focus more closely on getting that right side to a better spot. But while we're doing that, the right side of the heart doesn't have to do the work in that interim. It can only focus on getting better. And so these support devices can be really incredible. So VA ECMO is the most powerful and is probably the one that we utilize the most in patients with pulmonary hypertension. It allows us to completely support the right side of the heart. It can do the entirety of the cardiac work for the heart itself, and it allows the heart to completely rest. We do have probably more data in pulmonary hypertension on VA ECMO than we do in any other mechanical circulatory support device. But even in that setting, we don't have any, say, clinical trials that actually look at how these patients do on VA ECMO, and if they do better on these devices than they would if we just maximally treated them with medical therapy. We have looked at how patients with acute PE or blood clots in their lungs do with ECMO. And that's an acute form of right heart failure. And there was no benefit seen, no mortality benefit seen in those patients when they were treated with ECMO versus without. But we do utilize this device not infrequently in order to support patients who are failing, who we think we can get the right side of their heart better. And it's really been life-saving for many of them. There are, because of all of these challenges with these mechanical support devices in pulmonary hypertension, we have been working to develop new devices that are studied exclusively in patients with pulmonary hypertension. We've talked about how, right heart failure is, a significant problem that's associated with an increased risk of dying in patients with pulmonary hypertension, and how at times our maximal medical therapy isn't enough. And we've also talked about how these platforms really aren't designed for PH patients. And so developing a platform or a device that has been studied exclusively or studied especially in pulmonary hypertension patients and found to be beneficial, it would be a huge development and potentially hugely beneficial to all of our patients, especially those who we find to be failing. They're in the ICU and they're not doing well and they're failing everything that we're throwing at them. And so we've been working to do that. And that's actually what our grant came from Team Phenomenal Hope for, was to potentially develop or to evaluate, to perform a proof of concept study in one of these devices. So we'll talk just a bit about that. So this is the device that, or it's a pretty similar device to the device that we are trying to use. And this is called a precardia balloon. Really what this device is it's a balloon that goes in to a vein in the neck. Like many of you've probably had right heart caths. It's a device that goes into a catheter in your neck, just like a normal swan does when you have a right heart cath, although it's a slightly bigger catheter. It goes down into the right side of your heart with a normal swan, but there's a balloon on it, and that's different than a normal swan. And that balloon actually stays outside of the heart in what we call the SVC, or one of the big vessels that feeds the right side of the heart from the top of the body. And what that balloon is designed to do is to inflate for a period of time. And if you go back to the concepts that we talked about how the right side of the heart functions and how it is it depends on the blood coming into it to have an output, but in pulmonary hypertension, sometimes that preload can be too large, and you can have too much blood there, you can have too much fluid, and it actually acts to further make the right side of the heart fail. So this balloon is actually designed to intervene on that. The balloon is designed, when it inflates, to limit blood inflow into the right side of the heart, so that the heart gets a more manageable, gulp. So instead of drinking, to use an analogy, instead of drinking water through a fire hydrant, you're drinking it from a glass. And that allows the heart to kind of compensate a little better and to kind of contract and ideally function a little better. And so that's really the gist of it. This balloon will serially inflate for a period of time, limiting blood inflow into the right side of the heart. And then and allowing the heart to kind of start to pump a little better. The balloon will then deflate, allow some more blood back into the right side of the heart, and then inflate again, and the cycle will continue to repeat. I should also say the right side of the heart gets blood from two areas, above it and below it. And so we aren't intervening on the blood return from the below, just the above. But that's what this device is designed to do. And that's what we are studying in decompensated pH. And we'll go more into that. This device has been studied, like most devices that I've been telling you about, in left heart failure. And that's where a lot of the prelim data came from that gave us the idea to start looking at this in pulmonary hypertension. So they originally looked at this balloon use in patients who had left-sided heart failure, where the left side of their heart didn't pump very well, or heart failure with reduced ejection fraction. And you can see here, and I'll talk you through this. So you can see here that these patients, there were 10 of them, presented with decompensated heart failure, and they were volume overloaded. So the right side of their heart had very elevated pressures here before they were treated. The left side of their heart had elevated pressures. And they also, as a result, had elevated pressure in their pulmonary vasculature too. So some of these patients actually did have pulmonary hypertension, and some of them had pulmonary hypertension that looked a little more like a normal pulmonary hypertension patient, and not like a heart failure patient. But they all had elevated pulmonary artery pressures as well. They used this device, so inflated it, like I was explaining, in their superior vena cava, left it inflated for a time period, allowed the heart to kind of pump out a little better, and then deflated it. And what they found was, at the end of this period of time, this was just a 5 to 10 minute use of the device, they found that the pressures in the heart had gone down really significantly, in a good way. So instead of having the mean pressure on the right side of the heart be 19 when they started, it was down to 9, which is a much more normal range. 19 is very elevated. So using this device caused the pressures on the right side of the heart to return to a more normal state. It caused the pressures on the left side of the heart to return to a more normal state. And it caused the pressures in the pulmonary vasculature also to come down and return to a closer to normal pressure. And certainly they weren't as significantly elevated as they had been prior to use of the device. So there was a lot of excitement about that in this 10-person study. And notably, when they used this device, the heart function didn't go down. So these drops in pressures actually weren't associated with any change in the heart function. Actually, the heart function stayed constant during this. It just allowed the pressures that the heart was feeling to go down. And so it improved the heart from that direction. That ultimately led to this larger study, which was just completed and actually just came out that looked at 30 patients with left-sided heart failure. So an even bigger cohort. And many of these device studies aren't large. This is a pretty good size study for some of these, but they did 30 patients. So 30 patients like before who presented with left-sided heart failure. And what they found in these patients, they actually left the balloon in this time for an even longer period. So not a 5 to 10 minute period, but up to a 24-hour period that this balloon was in. And they found that the pressures on the right side of the heart were very elevated before the balloon went in. And then over time, with the balloon in, came down, and they stayed down even 3 hours after the balloon was taken out. So it wasn't just a transient effect of the balloon being in there. The balloon actually impacted those pressures and continued to impact those pressures even 3 hours after it was removed. It also reduced the pressures on the left side of the heart, which for these patients was important. And it's also notable to say that many of these patients, in fact, almost all of them, had pulmonary hypertension as well. Not the exact same type that we typically see in, like, say, a patient with PAH, but they all had pulmonary hypertension. So to some degree, this device has been studied in patients with pulmonary hypertension. And that's reassuring. Additionally, if you look at how these patients reported feeling before the device came in and after, they noted significant symptomatic improvement. So you can see here, this is symptom improvement scale. So going up is better. And you'll see that their shortness of breath got better. They were able to take a deep breath. They felt less fatigued. Their leg swelling improved. And their dyspnea score actually also continued to go down with use of this device. So not only did it help the filling pressures on the right side of their heart, but they actually felt a lot better, and they noticed it as well. And so we looked at all of this and thought, wow, this could potentially be really a game changer for our patients with pulmonary hypertension. This device isn't subject to some of the constraints that some of the other devices that I talked to you about are. This device isn't impacted really by the pressures in the pulmonary vasculature. It doesn't depend on, it's not a pump that has to pump against that flow. It's literally just a balloon. And in that regard, it's probably better suited in a pulmonary hypertension patient than some of those devices that I showed you that pumped into the pulmonary artery. And also, we already have some preliminary data in pulmonary hypertension patients, at least some pulmonary hypertension patients, that show that they tolerate it. And so we used all of that to present this study to Team Phenomenal Hope, and that's what we've been working on for the past year with their wonderful support. So what we have been working on is just a single arm study of 10 patients. We wanted it to be patients who were pretty sick from pulmonary hypertension, presenting with pretty severe symptoms, so not really able to walk without noticing significant shortness of breath. And then when they came in, decompensated, and when they came in, their pressures showed that the right side of their heart was really under a lot of strain, and they had a lot of extra volume on board. So their right-sided filling pressures are very elevated, like in the studies that have already kind of been done. So we were trying to fit this population to kind of hug the line between evaluating this in a PH population that we thought could potentially really benefit from it, but also kind of doing it in a population that is, at least on some level, similar to the patients that have been studied in the left-sided heart failure studies with this device. And so we would inflate the balloon for a total time period of up to 5 and 10 minutes, like had been done in the prior studies. And then we would monitor to see, number one, is this safe? It's been proven safe in these other studies as well, but you always want to evaluate for safety. And then number two, what does it do for our patients? Does it help decrease the filling pressures? Does it help their pulmonary artery pressures come down? Does it actually help us diurese them? Because in some of the studies, patients with this device and have had really significant urine output when the device is in place. So it also seems to aid in diuresis in a way we don't fully understand. And so that's what we've been working on. Unfortunately, as one can imagine, trying to get a device study off can be challenging because everyone wants to, ensure that, every I is dotted and every T crossed. And we've really done our due diligence in terms of, have we designed this to, in a way that protects the patients as much as we can, but still, is looking to see if this can help them. And so we've been working to get this through the IRB, and I think we finally are almost there. And hopefully we'll have some really informative data for you very soon. But I think this device can be a real game changer, and we're really excited about it. So with all of that in mind, I did want to go through a case that kind of used some of these devices so that we can highlight how useful they are. So I'm going to take you through this, and hopefully it helps you kind of understand how we use these devices and how they can be helpful. And then we'll wrap up with some questions. So a 24-year-old guy, really lovely guy. And this is in some MD speak, so I'm going to translate it, but a 24-year-old guy who had a prior history of a left bleed on his brain. That had recovered several years ago, came into a hospital with back pain and a really elevated heart rate. And his blood pressure was a little low, and his oxygen level was not quite normal. They ultimately were concerned about a potential blood clot in his lungs, and they were right to be concerned. Let me see if I can get this to play. Yeah, okay. So you'll see here these black things. This is blood clot. I'm going to try and take it back if I can. But they saw a blood clot in his lungs. Does it loop again? You can see it here. So there's blood clot here, blood clot over here, and some further out. So he was noted to have a blood clot in his lungs, which can cause elevated pulmonary artery pressures and right-sided heart failure. And they got an ultrasound of his heart, like I'm sure many of you had, and it showed that the right side of his heart was really big and dilated, and wasn't pumping very well. But it also showed that he had a big clot sitting in the right side of his heart. So he had clot in his legs that was in the process of coming up through the right side of his heart and going to his lungs. And we caught it on echo. And while they were actually ultrasounding him, this guy really hit the jackpot, and he happened to have a hole in his heart in between his right atrium and his left atrium. And while they were ultrasounding him, they literally watched that clot in the right side of his heart go across to the left side of his heart. And then they watched it go to his brain. And while they were ultrasounding him, he suddenly developed left-sided facial droop and wasn't really able to speak and couldn't move the left side of his body. So that blood clot that they literally watched go across caused an acute stroke right in front of them. He also continued to get worse. So his right heart really wasn't handling this blood clot very well. And so he had progressively low blood pressures and really low oxygen. And so we started inhaled pulmonary vasodilators. We started a couple of different pressors, so the blood pressure support that we need. We started some rocket fuel to help his heart beat as fast as we could. And we intubated him, of course. And even with that, he was going down the tubes. His blood pressures were very low, and we couldn't oxygenate him. And so we emergently took him to the cath lab and put him on one of these pumps. And this is a nice example of where we're doing everything medically that we can, and we're using these drugs, but they're not working fast enough and they're not enough. And so we took him to the cath lab and we put these cannulas in. So a cannula that sucked blood from the right side of his heart, put it through the pump and through the oxygenator, and took it back to the arterial side of his circulation. So we basically bypassed his right ventricle. So his right ventricle is failing from this blood clot, and we put this device in and bypassed it, and we were able to support him with this device. this is an example of actually two of them. So some people have one on each side of their heart, but this is an example of the type of tubing, how big the tubing is to hold that much blood. You know, if you're thinking of a pump that handles the work of the heart, you have to move a lot of blood, and you have to move a lot of blood fast to do the work of the heart. And so that's what, you know, these pumps are doing. So they're getting blood's coming in, going around and around, and then coming back out again. And so one of these is actually in this patient functioning for the right side of the heart, and one's functioning for the left. But these are the types of pumps and the type of tubing that we use in a patient like him on ECMO. And then this is an example of the console that we use. So we're able to dial up how much we want the pump to do of the heart's work, and then monitor kind of how well that's going. So we brought him back to the ICU with ECMO on, with this big heart pump, while we were treating his blood clot. But we noted that we really had a hard time even with this machine, because we were sucking lots of the clot. He had lots of clot everywhere, and it was going into those cannulas and actually plugging the cannulas. And so we were having a really hard time, even with the pump on, getting the pump to kind of work with all of this clot that was everywhere. And so we ultimately had to take him to the operating room and switch to a different device, which we'll talk about. So we switched him to what you saw in there, a tandem RVAD. So the cardiac surgeons actually put a graft in, or a cannula in, to the left side of his heart, and then this cannula was fed into his pulmonary artery, actually. And so we kind of replumbed in a different way that allowed us to better support the right side of his heart. And we took a whole bunch of clot out while we were in there. So these are actually some of the clot that came out of his lungs in that instance. He continued to kind of struggle, though. And ultimately, we found that he still had pulmonary hypertension, even after taking all of that clot out. And even with the pump around his heart being on, the right side of his heart was still really struggling. So he was acting like a true pulmonary hypertension patient. And then we figured out that he still had a whole bunch of clot in. So you can see here, these are pulmonary angiograms. So this is actually a catheter in the blood vessels in the lung. And what you should see are these blood vessels going out all over. But you see these big voids where there's no blood vessels. That's because that's blood clot in him. So he still has all of these areas of blood clot, despite the fact that we went in and took a whole bunch out. He still had a lot more. And on this side, you see, we're not fully engaged up here, but you can see that there's still a lot of blood clot down here as well. So ultimately, we diagnosed him with CTEPH, and we had to initiate IV pulmonary vasodilators. And when we got the IV pulmonary vasodilators up high enough, actually, we were finally able to wean the pump down and off. And ultimately, with the help of all of these devices and the pulmonary hypertension meds, we were able to get this guy out of the hospital. And he was able to propose to his fiance, which he had been planning before he came into the hospital. He actually proposed to her right before he left, when he was finally able to speak again. And so, you know, with the help of these devices, we were able to get this guy back home in the setting of his right heart failure and pulmonary hypertension. And without the devices, it wouldn't have been possible. He would have passed, certainly. And so these devices in this particular instance, and especially having the option of going with multiple different devices, you know, they really saved his life. And I think that kind of highlights how important developing these are in pulmonary hypertension patients, because we have patients like this, and we need to be able to support their right heart in data proven ways, and in ways that are specific to pulmonary hypertension, like this guy. So I thank you for bearing with me for all of that. I know that was a lot. So in conclusion, pulmonary hypertension can lead to right heart failure. we now have a lot of medications and some mechanical cardiac support to help the RV recover. And we are working with Team Phenomenal Hope's help to learn and develop more of these specifically for pulmonary hypertension. So I want to say thank you again to the Team Phenomenal Hope for the work that you are all doing and for supporting this, and to all of the patients for inspiring me, certainly, with all of your strength and grit and determination, and for, for helping us to better understand this disease and being so involved and such advocates. It's truly inspiring. And I think that's it. And I'll take any questions.
I just want to thank Nikki for doing this. Awesome job, girl. Fabulous, really. So if anybody has any questions, you can either ask them directly by unmuting yourself, or you can put them in through the chat, whichever you prefer.
Hey, Patty George. So first,
I can see the cat. I know it's you.
First I just wanted to say really amazing talk. Holy cow, I'm really excited to see what happens when the IRB's in and you guys are starting to be able to do this study. It's super exciting, and there's definitely a place for something like this. My question for you, just for the audience, is let's say this device works. How often do you see yourself using it? Meaning, how often do you see people so sick that they need this kind of support, when you're thinking about, in terms of the general pulmonary arterial hypertension patient that you tend to see in the, in the cath lab and in your clinic?
I may be skewed, but our patients are actually really sick. We get a lot of connective tissue disease patients, and maybe some of it has to do with our referral area and coming from, some of the more rural areas and, late diagnosis. But, it's a fair number of times that, we see indexes that are, really low, 1.4, 1.5, and patients who are, syncopal. And, it can take time to, get the drugs actually working. So I think, certainly, we're trying it out in those patients, and I think it can benefit those patients. But I think there's also room to use it, not just in, patients you're initiating drug on, but potentially in patients who come in who have, other or have mixed shock. So who have, say, septic shock and a right ventricle that's really decompensated as well. Their pH isn't going well. Could we ultimately utilize this device to help, say, support them through that period when we're needing to give them fluid and, trying to toe this line of enough fluid, not too much fluid, when we're working to support their heart and their lungs, et cetera. Can this device, much like we use some of the support devices in left-sided heart failure, can we use these devices as a bridge to recovery for patients with pulmonary hypertension? And I think that's another potentially untapped source to evaluate that we just don't have really for a lot of our patients. So, I think certainly decompensated patients who come in, but I think also patients coming in with other etiologies who happen to have pulmonary hypertension that's not well treated. I think there's a real avenue there for those patients as well.
Well, look, you presented a case where it's perfect. Somebody who's decompensated from an incredible clot burden. I mean, they aren't a traditional PH patient, but buying them time from right heart failure from clot burden allowed the people taking care of them to try and fix everything else.
That's exactly right.
I think Patty's question is great, but I think once you have this and once you can show that it actually works, probably the indications that you could use it as will probably be expansive.
Thanks for that question, Patty.
Actually, it was the cat that asked it.
Thank you. She was listening too, just so you know.
She seems satisfied with the answer. Okay, any other questions? Okay. If not, I thank everybody who was online and listened to this. And I especially want to thank Nikki for taking time out of her day to present this. It's really exciting. And we're all just can't wait for the IRB to prove the damn thing so we can see where it'll go. All
Thanks.
right.
Thanks for
So
having me.
I wish everybody a good afternoon and a good rest of the weekend. Thanks a lot. Bye.
Thank you.
Bye, everyone.